Hello, myself Dr. Reha Rakhulia. I'm going to teach Gnrh Agonist triggering IVF cycle. Mhm. What trigger we usually use is HCG. HCG. Initially, we only used to use HCG, and after that, because why we only used to use HCG? Because GnRH agonist protocol was used initially. GnRH agonist protocol. How does GnRH agonist work? Is GnRH agonist first causes flare-up effect, which is essential the for triggering. If we have to trigger means we need a flare-up effect. And secondly, after sometimes it causes down regulation of pituitary when we are using GnRH agonist protocol. Then we cannot use GnRH agonist as trigger because it's already down regulated. So we cannot use GnRH agonist as a trigger. But in GnRH antagonist protocol and PPOS. PPOS is progesterone primed ovarian stimulation. In these two protocols, we can use GnRH agonist as a trigger. Okay, initially we only uses GnRH agonist protocol. That's why GnRH agonist trigger was not used. Now, see, oocyte maturation with GnRH agonist triggering, oocyte maturation and ideal luteal phase support is still in discussion. That does Gnrh agonist triggering we using that, do we get more matured oocyte or not? This is in discussion. And what is the ideal luteal phase support in Gnrh agonist triggering? That is also in discussion right now. Earlier study shows that because earlier we don't used to have a good luteal phase support, so higher pregnancy loss were there and low pregnancy rates were there. Pregnancy loss, miscarriage rate were high and pregnancy rate were low. Then lutotropic property, lutolytic, sorry, Gnrh agonist has a lutolytic property. Lutolytic property, that means it prevents from OHSS. It prevents from OHSS and but it may lower because corpus luteum is defective. So OHS is prevented, but it may lower the pregnancy rate. Okay. Like literature suggests, lutolytic property of GnRH agonist effective prevent OHSS, but may lower the pregnancy rate. Then luteal phase support. If we give a good luteal phase support, then good luteal phase support, then pregnancy rate can be in GnRH agonist triggering, pregnancy rate can be equivalent to HCG triggering. Okay, here it's optimizing luteal phase profile, yield pregnancy rate comparable to HCG triggering. Then indication of GnRH agonist triggering. First is high risk of OHSS. As we have already seen, it reduces the OHSS risk. So if patient is having high risk of OHSS, like PCOS patient, we'll use GnRH agonist triggering. Second is oocyte donor. Oocyte donor patient also will use GnRH agonist trigger. Third is elective cryopreservation. Elective cryopreservation, there can be three causes. Okay, three things will do elective cryopreservation mainly. First is medical cause, that is cancer related. Social cause, if someone wants to delay its pregnancy due to some social reason, then also will cryopreserve, and that is indication for GnRH agonist triggering. Then application applicable for if we want to do a PGTA, or if we want pre-implantation genetic testing, okay, then we'll again need to cryopreserve. Why do we need to cryopreserve in PGT? Because it sometimes takes days for the result to come. That's why we need to cryopreserve the oocyte. So even in PGT, we'll use Gnrh agonist triggering. Then if there is a premature progesterone rise, we know that pregnancy rate will decrease in premature progesterone rise. So we'll use Gnrh agonist triggering in that also, because we'll freeze the oocyte. What is the limitation? Limitation is first hypothalamic dysfunction. Hypothalamic, if already endogenous gonadotropin are low, then we cannot use GnRH agonist as low GnRH agonist as triggering. We cannot use. Why? Because mechanism of GnRH agonist is it goes to pituitary and it stimulates the pituitary to release endogenous gonadotropin. And if endogenous gonadotropin is less, it cannot stimulate, it cannot have its effect. Gnrh agonist trigger cannot have its effect. So in hypothalamic dysfunction, we cannot use. And second is long-term suppression, like use of OCP. Like OCP will have a long-term suppression. So in that also, endogenous gonadotropin is low. So in such patient also, we cannot use Gnrh agonist trigger. Now, physiology of natural VS Gnrh agonist induced mid-cycle. What is there is LH surge and FSH surge. In both natural and Gnrh agonist trigger are similar. Okay, are similar. But natural surge in is 48 hour, LH surge, natural surge is of 48 hour, but Gnrh agonist surge is for 24 to 36 hours, and it occurs in 3 phases. It occurs only in 2 phases. Okay, it occurs. Gnrh trigger is surges shorter. Shorter means 24 to 36 hour only, potentially affecting the corpus luteum formation. That's why corpus luteum is defective here. Corpus luteum is defective. In this we have done. Now, FSH surge. We'll talk about FSH surge now. FSH surge is not fully understood, but it is helpful in oocyte maturation and resumption of meiosis. First function. Second is support the oocyte cumulus complex. It supports also, and it helps in detachment also. Detachment of follicle from the oocyte complex. Third is FSH causes LH receptor to grow in the granulosa cell. Okay. FSH granulosa cell में LH के receptor को भी it increases. Then short LH surge with GnRH agonist. If we this one. This I have already explained that natural ovulatory surge, it occurs in 3 phases. First is abrupt onset. In which it will be of 14 hours. This is natural surge. Then it's plateau phase that will be of 14 hour. Then there will be a gradual descent that will be of 20 hours. 14 and 20 hours. This is the natural surge, and in the GnRH in GnRH agonist surge, what will be there? Abrupt, rapid ascent and moderate descent. This will be of 4 hours and this will be of 20 hours. 4 hours and this will be of around 20 hours. So this is आपका rapid ascent and moderate descent. This is Gnrh agonist triggering. This is short. That's why corpus luteum is defective. So this short LH surge can lead to oocyte maturation and ovulation. But oocyte maturation and ovulation, but corpus luteum will be defective. Now we'll talk about advances insights in follicular fluid dynamic and granulosa luteal cell functionalis. follicular GnRH agonist trigger, I have already told, LH and FSH rise will be similar to the natural cycle. In GnRH agonist trigger, LH and FSH rise will be similar to the natural cycle, but the progesterone level will be less, decreased by 25%. Okay, need to give it in a, that's why we need to give progesterone in a luteal phase in Gnrh agonist trigger. We need to give the progesterone in luteal phase in Gnrh agonist trigger. See, it's written that LH and FSH is similar to the natural mid-cycle surge. Progesterone is decreased. And another thing is that estrogen inhibin both A and inhibin B. Inhibin B is secreted by granulosa soil. Inhibin A, corpus luteum. These three will be similar to the HCG. In GnRH agonist, these three will be similar to the HCG, means the level are similar to the HCG. This suggests the similar maturity and development. Okay. As we all know, GnRH agonist is slightly similar to the natural surge. So efficient oocyte maturation will be there, but there will be efficient oocyte maturation, but there will be decreased pregnancy rate. Generation led to efficient oocyte maturation because it replicate natural surge. However, decreased luteal, okay, because of the decreased luteal progesterone, pregnancy rate will be low. Okay. Now we'll talk about the molecular mediators. Molecular mediators are like amphiregulin. See, I've made amphibian also to remember frog. Amphiregulin and EGF like family member. What happens to this? These two increases after LH and HCG exposure. Okay, these two increases. But after giving GnRH agonist trigger, these two decreases. Similarly like natural cycle. Even in natural cycle, these two decreases, and in GnRH agonist also, these two decreases. So by this, we understand that LH and HCG have some complex role in follicular maturation. Okay. Then this differential expression suggests a nuanced role of LH and FSH in follicular development, influencing the strategies. We saw that amphiregulin and EGF-like family member increases after the LH and HCG exposure, but it decreases after giving GnRH agonist trigger or in natural cycle. Then VEGF, angiotensin 2 and their role. We all know VEGF and angiotensin 2 leads to OHSS. Okay, so what does GnRH agonist trigger do? GnRH agonist trigger decreases these two molecules, decreases VEGF and angiotensin 2. So what will it do? It will prevent from OHSS. This is clear. GnRH agonist trigger decrease in VEGF and angiotensin 2. So it will decrease the OHSS risk. Now we'll talk about luteal cell functionality. So post-trigger within 48 hours, if we see the granulosa cell or luteal cell, post-trigger, if we see the granulosal cell, uska viability and functionality is equivalent to HCG trigger. Means they are viable, means they are working. like HCG trigger only we saw. So what do? We in luteal cell, in vitro we take luteal cell and we add HCG in it. So it started secreting progesterone. Okay, so अगर हम luteal phase support देंगे तो IVF outcome optimize हो जाएगा, because these cells are still working. These cells are viable and functional, luteal phase cells. Though it is not producing Gnrh progesterone, but these are viable. So if we give HCG, it will secrete progesterone, and there so pregnancy rate will be equal to the HCG. Okay, it will give a good luteal phase support. See, as we can see here, Gnrh agonist trigger, it causes a rapid luteolysis, but we'll see granulosa cell and luteal cell within 48 hours, and we'll see that viability is maintained and functionality is maintained, and it can produce progesterone if we give HCG in vitro. So if we'll give a good luteal support, pregnancy rate will be equivalent to the HCG trigger. Then how Gnrh agonist is administered? There are two ways, okay? Subcutaneous injection and nasal route. Subcutaneous injection are triptorelin, buserelin, leuprorelin, and neferelin. And buserelin and neferelin can be used as intranasal also. They can be used as intranasal also. Then okay, this we have already discussed, that Gnrh agonist triggering can be used for Gnrh antagonist and PPOS for LH surge suppression. जो premature LH surge होता है उसके suppression के लिए ये दोनों चीज यूज हुई हैं. अब too high, if the dose is too low, what will happen? Will there won't be enough dose for sufficient LH surge, and if it's too high, then there will be more side effects and diminished efficiency. Okay, doses in most of the studies, doses are triptorelin is used as 0.2 milligram and leuprorelin is used as 1 milligram. Though personalized individual dosing is needed. Every patient will have to individualize the dosing. Okay. Okay, here we saw influence of body mass index on Gnrh agonist efficiency. We saw that when greater than 25 BMI was there was a varied response in oocyte maturity and quality. So we'll have to decide dose on the patient specific factor. In BMI, we'll have to give more doses in more BMI greater than 25. So that way we'll have to decide dose on the patient specific factors. Okay. See here, we can see by the flow chart, BMI influences Gnrh agonist efficacy. Potential need for dose adjustment. Higher BMI, oocyte maturity and quality had a varied response. So importance of patient specific factor in dose decision. Then optimizing the timing of Gnrh agonist administered. When we give a Gnrh antagonist as a protocol to suppress the premature LH surge, this is given. Then there will be the window time period. Then we'll give a agonist trigger. Okay. This window is important. It will decide the mature oocyte retrieved and the fertilization potential. So we need more studies on how much window it should be. This window is important from the Gnrh antagonist to the timing from the Gnrh antagonist to the Gnrh agonist trigger. Then in some studies like Horowitz et al., we saw that there was a comparable oocyte retrieved M2 oocyte fertilization rate when Gnrh agonist, when this window period was less than 2.5 hour or more than 7 hour. It's just one study. In that we found that even if it was given less than 2.5 hour or it was given greater than 7 hours, oocyte retrieve, M2 oocytes and fertilization rate were not changed. Okay. Now we need further studies for it. Future research should focus on personalized medicine approach, include dosing and timing optimization, and should consider the patient-specific factor like BMI. It will enhance the IVF success and the safety. Then we'll talk about Gnrh Agonist present a viable alternative to HCG with benefit of. What is the benefit is it decreases the OHS risk and mimics natural cycle for the oocyte maturation. Okay. Oocyte yield after Gnrh agonist trigger. Okay. Studies shows that Gnrh agonist and HCG oocyte yield is same. Oocyte yield is same in Gnrh agonist and HCG. But Humidin et al. One study was there. This shows that M2 oocytes increase M2 oocytes and increase more embryos oocytes and embryo were more in Gnrh agonist trigger. This was one studies which suggests this. Okay. Now there were two studies on LH level post-trigger. LH level post-trigger. I'll explain it with a flow chart. Post-trigger and progesterone LH level. In Kumar et al. Study, it was post-trigger and LH and progesterone. LH and progesterone were strongly correlated with total and mature oocyte. Total and mature oocyte. Okay, total number of oocyte and total number of mature oocytes. Now we saw in Chen et al. That if LH is less than 15 and progesterone is less than 3.5, there is a chances of having empty follicular syndrome. And if LH is less than 15 international unit per liter, then probability is 18.8%. Probability of having EFS is 18.8%. And according to Chen et al., the effect is on oocyte yield, but there is no effect on oocyte maturity. Effect is on oocyte yield, but not maturity. Here it shows Kumar et al. That both oocyte yield and oocyte maturity was affected. But here it shows that only oocyte yield was lower, but not the oocyte maturity. Advantage of Gnrh agonist trigger over HCG. Gnrh agonist will have a more mature oocytes, according to many studies, will have good quality, early embryo development, and there will be a different hormonal milieu, which can increase the outcome of IVF. 4. Mature oocyte quality is good, early embryo development, and hormonal milieu will be different, contribute to the improved outcome. Now predicting success. We have to predict that will oocyte retrieval will be successful. Like then we'll decide, should we proceed with the retrieval or should we administer a rescue HCG dose? This theory I'll explain with the flowchart. This is that, okay, we'll predict the successful oocyte retrieval. And in all these, there is decreased chances of successful oocyte retrieval. Decreased chances of Gnrh agonist trigger working. Okay, that means it won't work in these conditions. What are these? But what are these conditions? These are post trigger LH. Okay, post trigger LH less than 15 international unit per liter. What we'll give? We'll give GnRH agonist trigger. GnRH agonist trigger. Surge will be there. Then after 12 hours, we'll see for LH. And if it will be less than equals to 15 international unit, there is a chances of failing our trigger. Okay, first condition is this. Second is suboptimal response correlate with low serum FSH. Even in first, second day, there will be low serum FSH that is less than 0.1 milli international unit per ml and LH less than 0.1 milli international unit per ml. Second is low LH on the day of trigger. Low LH is less than, we'll do the LH on the day of trigger. When we are going to give the trigger, we'll do the LH values. Okay. Trigger. We'll do LH values here. Okay, we'll do LH values, and if it's less than 0.5, we usually don't use GnRH agonist trigger in this case. Then long-term OCP use. I have already told it in the limitation of the GnRH agonist trigger. Then low LH at the stimulation start and low BMI. Very less BMI also, there is chances of failure. Then this is, I have explained it in tabular form also, flow chart form also. This is a retrigger protocol. See, if we give GnRH agonist trigger and these are the ovaries, we do the retrieval on this ovary and we saw that there are no follicle. There are no follicle. What we'll do is, we won't go for the contralateral ovary. We won't go for retrieval for the contralateral ovary. We'll give retrigger with HCG and then we'll schedule repeat retrieval in the contralateral ovary after 34 hours of trigger. Okay. First scenario is this. There are two more scenarios. Second scenario is when we, after 12 hours, we have given GnRH agonist trigger, and after 12 hours of the trigger, we saw, we saw there is no LH and progesterone surge. There is no rise in LH and progesterone. What we'll do is, we'll retrigger with HCG and we'll schedule our oocyte retrieval after 35 hours. Okay. Then third scenario is when there is a surge in LH and progesterone, but there is a suboptimal surge after 12 hours of giving GnRH agonist. Okay. 12 hours of giving GnRH agonist, we did the LH value and it is coming to be less than 15 international unit per liter, but it is not, it is the surge, but not optimal. It is a suboptimal surge. Okay. What we will do in this case is, there are two things we can do. First is, we'll retrigger with HCG and plan according to our retrieval according to GnRH agonist trigger. Okay, like A. This is a A scenario. Planned according to means we'll retrigger with HCG, but from the first trigger, we'll plan our oocyte retrieval. Means when from the first trigger, when we have given GnRH agonist trigger before this HCG trigger, we'll plan according to that. Like after this, we'll see 36 to 40 hours after GnRH agonist trigger only. Though we'll give HCG trigger, but we'll plan according to GnRH agonist trigger. Second is cancel the cycle. See, again, I have explained this. Retrigger protocol. If no oocyte retrieve, will in the contralateral ovary, will give the HCG trigger and will repeat oocyte retrieval according to this HCG trigger 35 or 36 hours later. Then in post-trigger serum label, we'll see after 12 hours. LH value after 12 hours, we'll see if LH surge is not present, and if it's a progesterone surge and LH surge is not present, we'll retrigger with HCG and we'll schedule the oocyte retrieval according to the HCG trigger. But if there is a suboptimal LH rise, that is less than 15 international unit per liter, then there are two things, A and B. A is we'll retrigger with HCG, but we'll plan according to the GnRH agonist trigger. Means when we gave GnRH agonist trigger, if we saw after 12 hour HCG, we look for the LH level, and if it is less than 15, okay, then what will we do? We'll give HCG, but we'll plan our trigger according to the GnRH agonist. That means when we gave GnRH agonist, uske 36 hours later, we'll do oocyte retrieval, okay, or we'll cancel the cycle. In this, in no LH and in previous scenario, second scenario, no LH and progesterone surge, what we were doing, we have given GnRH agonist, okay. Then after 12 hours later, we did LH. If LH value is not appropriate, no LH surge is there, no LH or progesterone surge is there, we'll give HCG, and after 36 hours of HCG, we'll do oocyte retrieval. Can you see the difference? Here we are doing after 36 hours of HCG. We are not taking GnRH agonist for our oocyte retrieval, but here where there was suboptimal surge, we are doing oocyte retrieval according to our first trigger, that is GnRH agonist trigger. Then managing EFS and suboptimal response. Okay. Will identify at-risk patient like low LH level post-trigger. So either we'll do retrigger protocol as we have already discussed, or we'll use dual trigger for them. Okay. First we'll identify. I have told you now who all to see, what all to see. If the patient is at risk, either we'll give a retrigger protocol or use a dual trigger. Then dual trigger strategies, clinical implication. What is dual trigger? Dual trigger means we are using both GnRH agonist and plus HCG. What are its benefits? Okay, benefits are oocyte yield will be more. There will be more mature oocyte. There will be high quality embryos, but there will be decreased EFS risk. EFS is empty follicular syndrome risk. Okay, these are the benefit of using dual trigger. Now doses. Doses is HCG. It was compared in one study. In RCT, it was compared between HCG 10,000 and GnRH agonist plus HCG 10,000, and it was found that GnRH agonist plus HCG 10,000 was better. Means dual trigger was better. It has higher number of oocyte, more mature oocyte, as well as clinical pregnancy and live birth rate per more in dual trigger. See, dual trigger is combination of GnRH agonist and HCG. In clinical trial, dual trigger shows benefit in improved oocyte yield, more mature oocyte, high quality embryos, and reduced EFS. Randomized control trial shows better outcome in dual trigger group. Systemic review and meta-analysis shows higher live birth rate with dual trigger. Then optimizing dual trigger strategy. Here I'll show you with this flowchart. Zilber et al. Study shows about it included HCG and GnRH agonist. First, we gave GnRH agonist. Okay. Then 6 hours later, we gave HCG. 6 hours later, we gave HCG. 6 hours later. Then इसका हो गया आपका 40 hours later and इसका हो गया 34 hours later. 40 hours later with GnRH agonist and 34 hours later with HCG. We did oocyte retrieval. We saw that in these group there were more M2 oocytes and high quality embryos. And but because of HCG, there were high risk of OHSS. Okay, that's okay. Now, luteal phase steroid profile, natural cycle versus GnRH agonist trigger. Okay, now LH, everybody knows, supports corpus luteum and steroidogenesis. Okay, corpus luteum and steroidogenesis is promoted by LH. What does LH do is, LH increases the secretion of growth factor and also cytokine growth factors like VGF and fibroblast growth factors. These helps in implantation. Luteal phase in natural cycle. Okay, this help in implantation. So LH regulatory role is in synthesis of prostaglandin, stimulation of synthesis of prostaglandin, stimulation of embryonic growth, and maintenance of pregnancy, Hmm? Beyond ovary, LH receptor are also present in other structures. I'll see this with this flow chart. Okay, LH is a luteotropic hormone. LH receptor are also present in the fallopian tube, which secreted tubal glycoprotein stimulation, which does tubal glycoprotein stimulation, which affect tubal glycoprotein stimulation. In endometrium also, it has its influence, which initiate the pregnancy and maintain the pregnancy. Even in placenta also it is there, and it also increases the prostaglandin secretion. In early fetal cells also it is present, so it also help in the embryonic growth. Now, impact of GnRH agonist trigger on luteal phase. GnRH agonist trigger का luteal phase में क्या impact होता है? जो GnRH agonist trigger luteal phase with GnRH agonist trigger and luteal phase with post HCG trigger. Luteal phase with GnRH agonist trigger is shorter, that is for 9 days, and with HCG it is for 13 days. Okay, and so with GnRH agonist there is lower estradiol because corpus luteum is defective, so there is lower estradiol and lower progesterone. This is all because of the shorter LH surge. This is all because of the shorter LH surge, as we have already discussed. So there will also progesterone will be less, progesterone production. So there will be early luteolysis will be there. Okay, corpus luteum is defective and early luteolysis will be there. Then okay. LH has two type of pulse. One is it has a pulsatile release and it has a basal release. Okay, what happen is after giving GnRH agonist, we saw pulses on day of retrieval and 48 hours later. So pulses remain similar. Pulses remain similar but there was decreasing amplitude. Amplitude was of pulse was decreased. And second, basal LH. Basal LH secretion through pituitary was also lower. Okay. There are two types of pulse, LH pulse and basal LH secretion rate. Impact on progesterone and estrogen. Shorten LH surge will correlate with decreased progesterone production. Serum level of progesterone and estrogens are significantly lower throughout the luteal phase with GnRH trigger than an HCG trigger. This we have already discussed, that E2 and progesterone level will be decreased in GnRH agonist trigger in the luteal phase. Luteal phase we have already discussed. I'm again telling, okay? Again, I'm making it luteal phase of GnRH agonist and luteal phase of HCG. In GnRH agonist, it is 9 days. In HCG, it is 13 days. 13 days. And there will be lower estradiol and lower progesterone in GnRH agonist trigger. Then, Gnrh Agonist trigger induces oocyte maturation but does not sufficiently support the natural luteal phase. Now, mechanism of inhibiting LH release. What is the mechanism for inhibiting LH release? There are two mechanisms on inhibiting LH release in GnRH agonist trigger. First is after a flare effect, it started having down regulation action. So down regulation action has started. Okay. Second is supraphysiological level of P4 and E2. It will give a negative feedback to the pituitary and hypothalamus through ultra long loop, and there will be decreased secretion of LH. These two are the mechanisms for decreased LH secretion. Mechanism inhibiting LH release. Resultant is early luteolysis, impact pregnancy outcome. Even early pregnancy may not rescue the corpus luteum function. Even if early pregnancy is there, corpus luteum function would not be rescued. Okay. Now, markers of luteal function. Okay. Inhibin A and pro-alpha C. Inhibin A and pro-alpha C should go up. But after GnRH, these are the marker for corpus luteum health. These shows the health of corpus luteum. But by after giving GnRH agonist trigger, these two, inhibin A and pro-alpha C, these both go down. That means corpus luteum is not healthy. Okay, not healthy. Corpus luteum is not healthy. And second is there is altered gene expression. Altered gene expression. Indicator of initial corpus luteum function. Now, this I'll explain with the help of flowchart. Okay. Kale et al. Saw that when we give GnRH agonist trigger, there are two molecules, prorenin and 17-hydroxy progesterone, 17-alpha hydroxyprogesterone. These two rises, these at day 5 and this rises at day 2, but later decline at day 9 when we give GnRH agonist as a trigger. When we give GnRH agonist as a trigger, these two rises, prorenin, but decline at 9th day. Okay. What does that mean? Corpus luteum function continuation, at least initially. That means corpus luteum, because initially it was more, but decline at the 9th day. That means corpus luteum function initially was normal. Okay. Then luteal phase consideration in spatial population like PCOS patient. Okay, now we'll see that PCOS patient, there is raised LH. PCOS patient, there is more LH, okay, and there is decreased sensitivity to hypothalamus. Sensitivity at hypothalamus. Like when we give progesterone, there won't be hypothalamus won't be that sensitive to progesterone negative effect. Okay, it should be sensitive to negative effect of the progesterone, no negative feedback effect of the progesterone, but it won't be that sensitive in PCOS patient. In PCOS patient, progesterone won't be that sensitive to negative, hypothalamus won't be that sensitive to negative effect of the progesterone. So this way we can, because of this, we know that GnRH agonist trigger will work more efficiently in these patients. So that's why the role of individualized approach is there. Individualized approach role is there. Okay. Now what is next is modifying luteal phase support to enhance pregnancy rates. Now there are three types to modify luteal phase. What all we can do is, first is exogenous steroid support will do. Second is low dose HCG we can give. Third is recombinant LH we can give. Okay, three things we can do. This will do what will it do is, this will increase the pregnancy rate after FET, after FET, frozen embryo transfer, without raising OHSS risk, aimed at increasing pregnancy without raising OHSS risk. Okay. See, here we can see that what three things we can do for luteal support in ART after GnRH agonist trigger. We can give intensive exogenous support like serum estradiol and serum progesterone, or we can give adjuvant HCG administration at the time of retrieval, at the time of trigger. Okay, then we can give luteal phase, recombinant luteal LH administration, but in this close monitoring is required.